On air.
Hello, everyone. Welcome to the EAU Top 10% News on Stones. It is my great pleasure to introduce you to this session and listen to wonderful presentations which are selected from the best of the best on stones. My name is Professor Bhaskar Samani. I'm going to be chairing this session along with my friend and colleague, Dr. Patrick Crumber. So we will be following a specific schedule. We will introduce the session, an individual topic, and then there are 2 minutes for presentation and 2 minutes for questions, which you can ask the chat box. So if you're all ready, we can start with the first presentation. And the first presentation is a Wisconsin Quality of Life Machine Learning Algorithm for Predicting Quality of Life in Kidney Stone Patients by Dr. David Dan Nugent, please.
Thank you for the opportunity to present this work. This work is a presentation on behalf of the Wisconsin Stone Quality of Life Consortium. I have nothing to disclose. Urolithiasis is a disease with complex symptoms that poses a significant burden on the quality of life of those affected by it. As such, an overarching goal of the management of urolithiasis is to improve quality of life, and patient-reported outcomes play an important role in guiding the management of the disease. There has been increasing efforts, including the development of certain tools, to specifically measure the quality of life of kidney stone patients. Our research question was, can we predict patients' health-related quality of life based on readily available demographic, symptomatic, and clinical data? We relied on the Wisconsin Quality of Life Questionnaire, which was developed at the University of Wisconsin-Madison by Dr. Peniston and Dr. Nakada. We used data collected for the development and validation of the Wisconsin Quality of Life Questionnaire to build gradient boosting and deep learning models to estimate quality of life as well as classify quality of life into quintiles. In terms of results, we found that the gradient boosting model outperformed the deep learning and multivariable lasso regression models. In terms of quintile stratification, we found that the gradient boosting model had an average out-of-sample AUC curve of 0.70 and that it performed best in terms of stratifying patients between the lowest quintile and the highest quintile. On this slide, you can see the ROC curve and the confusion matrix, which basically represent the same concept. You see that our model is best at predicting the highest and lowest quintiles, where there is the most overlap between the true label and the predicted label, and that our model underperforms when it comes to classifying patients in the middle quintile of quality of life. In conclusion, our first version of the Wisconsin Quality of Life machine learning algorithm can adequately estimate kidney stone patients' health-related quality of life and outperforms linear models. In the future, with more data coming from the Wisconsin Quality of Life study, hopefully our model can improve to be used in more refined clinical settings. Thank you.
On air.
Thank you very much. And we don't have any Q&A at the moment, so I know my colleague Dr. Crumback has got a question. I'll let him carry on.
So I have no question. I just remarked this was a very mathematical presentation, a very mathematical issue, and I just wanted, perhaps somebody has an idea to know if this was to test different kind of cares, different kind of strategies if you have a patient with a stone, and to check out the best one. But as there's no question and answers, was this your guess too, that you could use this model as a test to predict different outcomes in different strategies? Because the guy has a stone, he has pain, yes, but what's the clinical impact, the clinical use of a questionnaire like that? But I don't think if Dr. Nguyen is not there, so perhaps I just leave the question there.
Sure, we'll leave it open, and hopefully when we catch it next time, we can ask him there. Thank you. Our next presentation is Dr. Gao. He's going to talk about development of risk calculator to predict spontaneous stone passage in patients with acute urinary colic. Dr. Gao, please.
Good afternoon. First of all, I'd like to thank EAU 2020 for giving me the opportunity to present on the development of a risk calculator to predict spontaneous stone passage in patients with acute urinary colic. I'm presenting this on behalf of the British Urology researchers in surgical training. Renal colic is a significant problem. We know that about a quarter of all stones may not pass spontaneously. and they can represent an emergency. Furthermore, due to the lack of evidence on predicting which stones may pass spontaneously, MIMIC study collected over 4,000 patients' data in 2016 and 2017, where we found that about 2,500 patients were discharged with initial conservative management, and 3/4 of them passed their stones spontaneously. We looked at variables including gender, neutrophil count, hydronephrosis, hydroureter, stone size, and stone position. Logistic regression was used to analyze the set of variables with the highest predictive ability for spontaneous stone passage, and the corrected beta coefficient after internal validation was used to create a nomogram, which you can see on the next page. Nomogram can then determine a probability of spontaneous stone passage between 20 and 95%, and following internal and external validation, the C statistic of the corrected model was 0.77, indicating good discrimination. And here is the calculator that we've developed, which we believe has significant potential in guiding the clinical management of patients with acute ureteric stones. Furthermore, given the current COVID setting, it's more important for us to better select patients who might be suitable for conservative management. Thank you very much for listening, and I'm happy to take any further questions.
On air.
Hi, Dr. Gao. We've got a question from one of the listeners. So this was obviously British data, and I know this study, and it's really well received. The question is, have you validated this model on another group of patients?
Yep. So this is actually a study that was done in 6 different countries, including UK, New Zealand, Australia. And so what we have done is actually divided the data set into 2 different ones. So one from 2009 to 2014, and the other one from 2015 and 2016. So the first part of it was internally validated within one set of patients, so from 2009 to 2014. And the second data set was actually also validated, so what we call external validation from 2015 and 2016. In terms of future validation work, we're also planning to look at a different data set from Wales to see whether that is actually to see whether the model actually fits. But based on the current C statistic, we believe that it will be quite a good fit.
Dr. Promnak, if you have any other question. So you're on mute, Patrick.
Where can you download the calculator? I didn't find it. Because I think this is a very useful tool in daily practice. Huh? Very useful even for organization. And my second question would be, how does the fever, so the temperature, impact positively on the stone passage? That's all the other stuff, I got the logic behind it, but the temperature was somehow, do you have an idea?
So to answer your first question, the calculator, we've already made the calculator. It will be available on the Burst Urology website in the next, what we believe in the next 1 or 2 months. It will also be available on the Android store, free for all users to use. To answer your second question, which is in terms of fever. So actually, interestingly, in modeling, not every single factor has to have, must be, have a good confidence interval. Actually, we're not really sure what's the reasoning behind why fever is actually associated with one way of passing or the other, but rather so some of the variables don't actually have a statistically significant result, but in the context of the whole modeling process, the different factors actually interact and can actually result in they actually influence the probability of spontaneous stone passage, but it's actually stone size and stone position that have a statistically significant influence on spontaneous stone passage.
Okay, thank you. Mysteries persist.
We can go to the next presentation.
Yeah, thank you very much.
The next presentation, thank you very much, Dr. Gao. Next presentation is by Dr. Kampnell, who is going to talk about cost efficiency analysis of reusable versus single-use flexible ureteroscopy and the development of a formula to evolve to a cost-efficient model.
Thank you for the opportunity to present my poster about cost efficiency of a flexible ureteroscopy program. I have no potential conflict of interest to report. To determine which flexible ureteroscopy program would be most cost efficient in our center, a cost efficiency analysis was performed. A retrospective review of all costs pertaining to reusable flexible ureteroscopy occurred. Total cost per case after 794 cases was calculated and compared with 2 single-use flexible ureteroscopes currently available on the market. Costs taking into account for reusable ureteroscopy were the purchase cost, the reprocessing cost, and the total repair cost after 32 repairs. The manufacturer's suggested retail price was used for Pusen and LithoVue disposable ureteroscopes. On a per-case analysis, the cost per case for reusable ureteroscopy was initially very high, but was quickly decreased to reach a plateau after approximately 400 cases at around 480 euros. After 155 and 247 procedures, a program with reusable scopes appeared more cost efficient than consistently using Pusen and LithoVue respectively. We have developed a mathematical formula that can identify if and how a hybrid system can be cost efficient considering an increased usage per reusable ureteroscope before needing a repair. Based on our own data, if we would, for example, hypothetically use respectively Pusen or LithoVue for 50% of the cases, the reusable scope needs 29 or 47% more users to stay cost efficient in a hybrid model. In conclusion, in our center, consistently using a reusable digital flexible ureteroscope is more cost efficient than the consistent use of a single-use flexible ureteroscope after 155 to 247 cases. Our mathematical formula to calculate the necessary increase of use of reusable flexible ureteroscopes to be cost efficient in a hybrid model can help colleagues to identify whether or not a hybrid system may be a feasible alternative to reusable scopes.
It's great, and I think there's been a big rise in the use of single-use scopes. So don't have any other question on the chat box, but I've got a question for you, and I'm sure my friend Patrick would have it as well. Perhaps the feature might be selecting cases where you're going to break your scopes more, isn't it? I mean, that'll make it much more efficient if you can predict which cases you're going to break your scope, and you can use a single-use scope for that one. What do you think?
Of course, there will be cases that are more difficult than others, and that will be the cases that we are preferable use the single use. We think as big stones, especially in the lower pole, we think on complex anatomy, for example, congenital malformations and etc. Also, when we expect to use the laser for a long time, we can use a single use, etc. So that criteria are a little bit common, but they also are really for every user for their own.
Patrick?
Yes, well, first of all, congratulations. This is a very interesting topic. Just to understand your concept of your formula of the need for increased use of reusable flexible scopes. So in your case, you had, if you used 50%, you would need to increase it by 70% before it breaks. So now you use it for, I don't know, 60 procedures, and you would need to use it for 90 procedures before it breaks,
yes.
or something like that.
Yes, and that shows how difficult it is to be cost efficient when using single-use flexes. The best what we get is when we use, for example, the Fusion scope in 50% cases. Then we have to raise in it was 29%. So
Yeah.
maybe that's well feasible.
Okay. So yes, perhaps you should give the first year assistant then always a single use.
That's a good idea.
Just to add, I think one thing we shouldn't forget is when it comes to training people, they're more likely to break. So one of the advantage perhaps of single use is when it comes to training.
Yes.
You're more relaxed with training, so that you can't measure it, of course, in cost. But yeah, it is an interesting debate. I'm sure it will carry on. Thank you so much.
You're welcome.
So with that, we will go to our fourth presentation, which is a risk of unplanned healthcare utilization in patients undergoing ureteroscopy with uncorrected bleeding. And we have Dr. Hillier talking to us about it. Thank you.
Thank you for taking the time to listen to this project. AUA guidelines recommend ureteroscopy as well as use of a ureteral access sheath as a first-line therapy for patients that require intervention for stones while on continuous anticoagulant or antiplatelet therapy. We sought out to examine practice patterns, outcomes, specifically ED visits and hospitalizations within 30 days, as well as AUA guideline adherence within a surgical collaborative in the state of Michigan. Music Rocks maintains a clinical registry of patients undergoing ureteroscopy for urinary stone disease from a diverse group of academic and private practices. We included all patients undergoing primary ureteroscopy and divided our groups based on active therapy at the time of surgery. Patients holding therapy are included in the control group. Adherence to AUA guidelines meant that a ureteral access sheath was used during ureteroscopy for renal stones only in patients actively taking therapy. We identified a large group of patients actively taking anticoagulant or antiplatelet therapy at the time of ureteroscopy from 26 practices and 144 surgeons. The top two figures demonstrate practice and surgeon level variation in the frequency of performing ureteroscopy in patients actively taking anticoagulant or antiplatelet therapy. Each bubble represents an individual practice or surgeon. The size of the bubble demonstrates their total ureteroscopy case volume. The percentage of cases performed in patients actively taking therapy ranged from 0 to 21% for practices and 0 to 35% for surgeons. On multivariable analysis, neither therapy was associated with an increase in ED visits. Antiplatelet therapy was, however, associated with a significantly increased odds of hospitalization within 30 days, whereas anticoagulant therapy was not. Lastly, cases for renal stones in patients taking either therapy were no more likely to use a ureteral access sheath. In conclusion, significant variation in practice patterns exists in this population. Risk of hospitalization is increased in patients taking antiplatelet therapy, and ureteral access sheath use is not associated with either therapy. Thank you.
Nair?
Thank you very much. As we know, most patients now, are stone disease is increasing, and so is the use of anticoagulants and so on. So I think it is good to have some data. Can I just ask you, for these patients, in an ideal scenario, could some of them could have stopped and taking antiplatelet and anticoagulants? Because in my practice, if they can stop it, that's the best case scenario. They stop it for a period of time, then you restart it. Did you look into that, whether they could have stopped it? And could you comment on that?
Sure. So the music registry tracks nearly every ureteroscopy that's happening in the state of Michigan, and it's not necessarily related to this anticoagulant or antiplatelet issue. We track a lot of clinical outcomes. And so just based on the way the registry is built, we only track if the patient's actively taking the therapy at the time of surgery. So certainly within our control group includes patients that had stopped therapy in anticipation of surgery at the discretion of the urologist or primary care physician. So absolutely, we can't account for that. We don't know the number of patients that includes within our control group because it's not a question that's asked currently.
Okay. Patrick, any other question or comment?
Yes, I just want to know if you took, well, it's quite common question, is aspirin 100 milligram or 80 milligram, were they also counted as antiplatelet patients?
Yeah, so the anticoagulant question and the antiplatelet question are separate in the registry. Antiplatelet therapy includes aspirin 81 milligrams or higher, and then anticoagulant therapy includes Coumadin or warfarin, and then any of the novel agents.
And could you analyze from your data if the hospitalizations were due to an issue of the procedure or to some heart problems, so from underlying conditions?
Yeah, so that's a good question. We did do a multivariable analysis controlling for a Charlson comorbidity index, which is just some calculation of the amount of comorbidity the patient has. We could not specifically control for cardiac-related issues. However, this has been, the Charlson comorbidity index has been validated in use in studies and appears to represent overall health for the patient. So to answer your question, yes, in theory, we have controlled for, overall health of the patient, cardiac issues, that kind of stuff, as well as case complexity and some surgical issues.
Okay.
Thank you.
So we will continue with the next poster. The next poster, which speaks of a novel technique for second look PCNL, residual stone removal. So second look flexible nephroscopy in gas CO2 medium from Dr. Dmitry Korolev.
Good day, dear colleagues. My name is Dmitry Korolev, and I would like to present a pilot clinical study from Sechenov University, Moscow, Russia, on antegrade flexible nephroscopy in gas medium, new technique for residual stones removal. I have no potential conflict of interest to report. Residual stones after PCNL for complex forms of stone disease remain as a significant clinical problem. The objective of our retrospective pilot clinical study was to evaluate safety and efficacy of second-look flexible nephroscopy in carbon dioxide medium under local anesthesia for patients with residual stones after previous PCNL. Between 2013 and 2018, 22 patients with residual stones after previous PCNL were selected to undergo second-look flexible nephroscopy in carbon dioxide medium under local anesthesia. This study was approved by Local Ethics Committee at Sechenov University, Moscow, Russia. 13 patients before conventional PCNL was performed had complete Stockhorn stones, and other 9 patients had partial Stockhorn caliculi. The mean residual stone size and stone density were 8.3 mm and 1019 Hounsfield units respectively. Second-look flexible nephroscopy in gas medium using existing nephrostomy tract was performed under local anesthesia on postoperative day 3. The mean second-look flexible nephroscopy time was 42.8 minutes. No postoperative complications were experienced. Blood acid balance during the operation and 3 hours after it did not go beyond the limits of acceptable values. Stone-free rate was 86.3% at 1.5 month follow-up. 3 patients were excluded from the study. 19 patients remaining in the study successfully completed the procedure under local anesthesia with the mean NRS 2.1. The mean overall image quality during second-look flexible nephroscopy in carbon dioxide medium was 3.68. Second look, flexible nephroscopy in carbon dioxide medium under local anesthesia is an effective and safe method for residual kidney stones removal. Benefits of this technique are as follows: low stones migration rate and low postoperative complication rate. Limitations of this technique are related with pelvic calical system rigidity, making it difficult to adequately distend it with a gas, and residual stones with a diameter larger than 12 mm, which cannot be removed in one piece and will require the use of laser energy in liquid medium. Thank you.
On air.
Great, thank you so much.
Yes, Dr. Korolev, thank you so much. So, Bashir, do you have a question?
I think it's quite interesting because here we are in the era of COVID. Anything that can have a avoidance of general anesthesia is probably quite a good thing, and especially for second look, which is not uncommon. So what is the trick to doing it? How can more people, I know it's a pilot study, how can this become more widely adoptable? What are the problems, or how can people do it in their practice?
Yes, thank you for the question. As I mentioned, it was a pilot study, so we have a limited amount of patients. The technique problems, I think, are as follows. It's difficult of inflating of the pelvic calical system with the gas. So I think it's the main problem that we have during this study.
But how do you perform the local anesthesia? How you just infiltrate the tract? Do you give some sedation to the patient?
No sedation. We just insert the local anesthetic medication through the nephrostomy tube into the pelvic calical system and clamp the tube for 3 or 5 minutes. So then we remove the tube and insert the instrument into the pelvic calical system. So that's it.
Okay, and you probably you can't use an amplatz shaft, so you have to use, or you just put in the flexible scope. I saw on your photograph, you just put the flexible scope in without any amplatz, without any shaft, in order to create pressure, I suppose.
Yeah, and the other reason is if you put amplatz in, you can have bleeding. You can damage the track, and the visibility will be not so good. So we don't use the amplatz sheath. We do the nephroscopy without it, and it was nice because the second look, we usually perform second look in 3 or 4 days after previous PCNL, and the nephrostomy tract is reliable for insertion of the flexible nephroscope.
And you just have one shot, or you can re-enter it with the scope. If the tract already as established at day 3 that you can just take out the stone and then go in again?
The time from the previous surgery allows us to have a stable tract, So we could insert the instrument multiple times. It's not a problem.
That's very interesting, huh?
Thank you so much, Dimitri.
You're welcome. Thank you.
So the next poster is from Egypt, from Dr. El Karamani, the first prospective comparison of stone, guy, crows, and SRESC for predicting percutaneous nephrolithotomy outcomes. So assessment of calculating scores. Dr. El-Karamani.
Dear colleagues, this is the first prospective study comparing stone nomogram, Guy's stone score, Crow's, renal stone complexity score for predicting PCNL outcomes. I have no potential conflict of interest to declare. PCNL is highly successful in the management of large and complex renal stones. However, efficient prediction of stone-free rate and complication remains a challenge. 4 scoring systems are currently used for that purpose, but not evaluated in a prospective study. So, we aimed to prospectively compare their predictive accuracy regarding stone-free status and the development of complications. The scores were calculated and the acquisition time of each was estimated. All procedures were performed in the prone position. Complications were reported according to the modified Cleveland system. KOB and ultrasound carried out at the first postoperative day. Non-contrast CT was performed within 3 months for all patients, and the stone-free status was defined as absence of residual fragments more than 4 mm. ROC curve revealed that Crow's has the best accuracy in predicting stone-free status with area under the curve 0.86, while stone score has the best association with complications. Data acquisition time was significantly shorter for Guy's stone score in comparison with the other 3 scores. In logistic regression analysis, the number of involved calyces, stone multiplicity, and renal pelvic obstruction were significant predictors of stone-free status. Single stones are 9.6 folds more likely to be stone-free status, while number or mild renal pelvic obstruction has 4 folds more likely to be stone-free. In conclusion, the 4 scoring system had comparable predictive accuracy for predicting both stone-free status and complications. Stone and renal stone complexity score were easily applicable and provided better correlations with estimated blood loss and operative time. However, further studies are required to invent a universally agreeable scoring system to overcome shortcomings in the currently used scores. Thank you very much.
Well, Tarek, thank you very much. So, of those 4 scoring systems, which one do you use in your clinic now, or do you use any if you plan a PCNL, or you just do the PCNL?
Yes, actually, I usually use Guy's stone score because it is simple and can give an idea about stone-free status and the development of complications, and it can be used by junior to be calculated. So I usually use Guy's score.
And you use it to plan, I don't know, the probability of having to schedule a second look, or you use it to have a good stone for a resident or somebody who is in training, perhaps, or what's the direct clinical implication?
Regarding Guy's score?
Yes.
Guy's score can be used, can give an idea about stone-free status, and can be give an idea about the development of complications. And it is very rapid acquisition time, less than 1 minute. Calculated, so juniors can use it or count it efficiently.
Okay, Bhaskar, do you have any more questions?
No, I was going to ask if you had to choose one, not just you, if anyone had to choose one, just one, because there's so many, which one is the one that you'll say this is the one to choose?
I think the renal stone complexity gives a very good idea about stone-free status and the development of complications, and relies only on the stone distribution within the collecting system. No many factors could be measured, and it is, I think it is very simple and gives a good idea about the outcome of percutaneous nephrolysis.
Thank you so much. Thank you.
Thank you. Thank you very much. Thank you.
So the next presentation is from Michigan, the Moses technique. So pulse modulation with Moses technology improves popcorn laser litotripsy from Dr. Black. The stage is yours.
Previous in vitro evaluation of the effect of pulse duration on high-power popcorn laser lithotripsy has demonstrated that short pulse mode results in better sub-millimeter fragmentation when compared to long pulse mode. But it is unknown how pulse modulation modes such as Luminous Moses distance technology affects outcomes. Our objectives were to compare the effects of pulse modulation with Moses technology with that of short pulse mode on popcorn laser lithotripsy outcomes in an in vitro model based on fragment size distribution, amount of stone mass lost in fluid, and a laser to stone strike rate using high-speed imaging. Experiments were conducted using Bigo stones in an 11mm glass popcorn test tube. A 230 micrometer core Moses laser fiber was then introduced through a LithoView and held 2 millimeters above the stones with a 3D positioner. Experiments were captured using high-speed imaging at 10,000 frames per second. Using both short pulse and Moses distance mode, we tested 20 watt and 40 watt settings by firing the laser in 15-second intervals, delivering a total of 4.8 kilojoules. Stone weight was recorded pre and post experiment, and fragment size distribution was then determined using microsieves. Using high-speed videos, the strike rate was calculated by dividing the number of strikes occurring during a 1-second clip by the frequency of that setting. Strikes were then characterized as direct or indirect. When evaluating fragment distribution, we assess the fragments greater than 2 millimeters since this size threshold is associated with adverse outcomes after surgery. The observable trend favored Moses distance in creating less fragments greater than 2 millimeters when compared to that of short pulse mode. The largest difference was observed at 1 joule and 20 hertz, where Moses distance produced significantly fewer large fragments. For most pairwise comparisons, there was no significant difference between pulse modes for mass loss and fluid. However, MD at 1 and 20 hertz resulted in the most mass loss in fluid compared to all other 20 watt settings and performed similarly to 40 watt settings. MD mode resulted in an overall higher total strike rate as well. Indirect strikes were more common than direct strikes at a 2-to-1 ratio for both pulse modes. Specifically, at 1 joule and 20 hertz, 96% of strikes were indirect when using MD mode compared to 61% of indirect strikes when using short pulse mode. High-speed imaging analysis revealed that with Moses distance, a rebound bubble created by the collapse of the second vapor bubble occurred away from the fiber tip, in contrast to short pulse mode where it occurred at the tip. In conclusion, the pulse modulation may confer an advantage when compared to short pulse mode for popcorn laser lithotripsy, especially for lower power 20 watt settings. Moses distance mode resulted in less large fragments, more mass loss in fluid, and causes stone fragmentation through mostly indirect strikes. Pulse modulation with this lower power setting may be an attractive setting for limiting heat generation, improving visualization, and preventing fiber tip degradation.
There.
Dr. Black, thank you for this nice in vitro study. Well, as usual, I have a question using URS myself quite a lot. So you have one setting at 40 watt, which is quite a high amount of energy. Is this a setting you just used for the in vitro experiment, or do you use a setting like this also in vivo? Also regarding to the fact that there were some temperature measures recently published using 40 watt in a small piezo-calicil system. Do you use it like that or just in vitro?
It definitely can be used in clinical practice. I'm actually just beginning my urology training. It can be used in clinical practice as long as you're trying to mitigate the temperature with the proper factors. You have irrigation running, and you're cognizant of the fact that too much of that heat at one time will cause damage to the calos. So you definitely have to watch that. But the 1 in 20 is a much more attractive setting for actual clinical use. But this was a nice contrast, like I said, in an in vitro model to understand what are the power dynamics that kind of exist between those different settings.
Yes. Okay. Well, thank you very much. It has an answer. It answers a question. Huh?
Exactly.
So we'll pass to the last poster, also on lasers. So now the thulium laser in vitro comparison of ablation rates between a superpulsed thulium fiber laser and a holmium luck laser for endocorporeal lithotripsy from Paris. Dr. Pontier, allez-y.
Dear moderators and dear colleagues, thank you for giving me the opportunity to present this work about the in vitro comparison of the ablation rates between superpulsed thulium fiber laser and holmium laser for endocorporeal lithotripsy. I don't have any disclosure. The main objective of our study was to compare the efficiency of thulium fiber laser and hormone-like laser based on the ablation volumes. For this in vitro study, we used artificial hard and soft Becker stones comparing 3 TFL and 2 hormone-like laser settings. We were maintaining an average power of 15 watt, comparing fine dusting, and fragmentation mode. The experimental setup was using a robotic arm who was making a spiral trajectory with a vertically disposed laser fibers in contact mode with the stone, and after a laser emission of 30 seconds, we were able to dry out the stone, to scan them, and to measure the ablation volume using 3D segmentation and 3D slicer. As you can see for the results, TFL with 272 microns was 2-fold to 4-fold higher in terms of ablation rate than hormone-like laser with 272 microns also. And the interesting result is about the TFL with 150 micron laser fiber, which was still 50% higher in terms of ablation rates than hormone-like laser in dusting. These results were maintained again soft stones. As a conclusion, we can say that thulium fiber laser with 272 microns is 2-fold to 4-fold higher than hormone-like laser in terms of ablation rates, and thulium fiber laser with 150 microns is at least 50% higher than hormone-like laser with 272 microns. Thank you for your attention.
On air.
Frédéric, thank you very much for this nice new illustration of the thulium laser, which I personally use a lot for prostate. And every time I had a stone in the bladder, when I put the fiber on the stone and I push the gas, so the fiber springs, it's magic, but the fiber just shortens and the stone has a little impact. What's the difference in using this new thulium laser or new fiber, which makes the stone break and not the fiber? What's
Actually, the main difference is about the technology. We are talking about thulium fiber laser. Are you talking with thulium YAG or thulium fiber laser also?
No, both.
Both. Okay, because thulium fiber laser is very, very different from thulium YAG because it's not the same technology. Thulium fiber laser is made of a single fiber doped with thulium ions. Actually the produced laser is quite different because it's a 30 micron spread of laser.
Yeah.
It doesn't need any collimation, so actually the output power is maintained. There is no loss of power. This is one main difference. The other difference is about the bubble stream at the fiber tip, which is quite different from the Moses technology or the conventional hormone laser, because it's not a vapor bubble, it's an induced bubble stream, which we can suppose that it could improve the laser efficiency about the ablation. So actually, I think the thulium fiber laser is quite different from the thulium YAG in those aspects.
Okay. So and just it's a single-use fibers, or is it reusable fibers?
Actually, there is single-use fibers. For this study, it was not Olympus fibers. It was Boston Scientific fibers with. It was not a commercial laser generator. Okay. It was only for in vitro studies. So actually, I can't respond to your question, but the Olympus laser fibers are single use to my mind.
Yeah. Probably single use, yes.
Yeah.
So thank you very much. I have 1 minute left just to give an answer to two questions that were asked in the question and answer chats. So it's mainly on the CO2 second look PCNL. So one was from Munir Ahmed. So he just remarked that not being able to use a laser was a significant limitation, but that was already assessed by the Dr. Korolov. And if extra precautions need to be used because of the COVID environment now with CO2. So this is a question I can't ask, but I think the patients got all tested before going to surgery. So if you have a COVID-free patient, which I suppose they have in their hospital too, I would say there was no special precautions to be taken. So there's no other question for Dr. Pontier, which I thank for his precious contribution to this virtual Congress. I personally hope we will see each other next year again in person, everybody of us. And if there's no more requests from the EAU, I thank you all for looking and hopefully see you in person next year.
Thank you very much.